Bismillah ar-Rahman ar-Rahim, and welcome back to my educational third recording video for using CGM data to optimize diabetes care. I'm Dr. Hala Qasim Omar Khalafallah, Associate Consultant, King Saud University Medical City, Riyadh. Actually, we talked before about continuous glucose monitoring, how valuable is the data, how they standardize and organize it and organize each value of these metrics. And today I want to to make more about method of interpretations of the AGP reports. I hope it will be clear for all. This is my disclosure, and I will teach. It will include in my discussion the SMART goals and talking about quick method for interpretations of AGP reports, and the third part is talking about more tools to make it easier, like interactions with curve. So goal setting in diabetes self-management. As we know, before we talk about how difficult managing diabetes during daytimes for the diabetic patients. So we need to aid them during this challenge and make their life easier by adapting new methods and new technologies, and by creating good relationship between us and the patients, and just some sort of make the life easy for them. Okay, so one of these goals is a SMART goal. SMART goal, SMART denomination is for specific and measurable, achievable, A R for realistic, and time, T for timing. The SMART goal, actually, it was being first adopted early. There is nice paper for K. Planet and his colleague. They provide an example of how teachers can utilize the tools with the classroom setting to improve the student learning outcome. So it was being first adopted in a school environment, and they came out by fascinating results for exerting these rules. And in the diabetic fields, we have an early study by DeWalt, and they said in this study that setting small, achievable goals not only enhances people's ability to cope with their diabetes, but that people with diabetes who set and achieve their goals often necessitate additional behavior change on their own. So you tell him something, and then he make an effort, and he will come back for you by additional behavior change on their own, which more effective in their diabetes management. So by this role, it provides direct focus, motivation to diabetes self-management, and it is intervention is directly applicable to a certain target for timing range. So what do you mean by it? Specific, as for specific, need to be concise and clear targets, well-defined and unambiguous, and they need to be precise goals. Okay, measurable. You need to set specific criteria that can be measured, and to determine how much progress he made it. Achievable. Need to be realistic to achieve. There is no point in the setting goal you will never be able to achieve. And relevant. The goal you set must be directly related to the problem you are experiencing. And goals should be worked towards solving specific issue such as diabetes management, timely or time-bounded, should have a specific time frame for your adherence to. So setting a time frame will allow you to monitor your progress and result measurable over time. So moreover, setting a deadline will motivate you to work towards this goal. So we need this deadline. Okay, so let us take example of one target we want to achieve it by making these rules, SMART rules. So let us talk about one target of check blood sugar level. Okay, you are just regulating and discussions between you and your patient. Tell him, would you check your blood sugar level when you wake up from sleep and pre-meals? So by talking these words, that mean you will give him specific goals. We are talking about blood sugars monitoring, okay? So this blood sugar level should be done at particular number of times per day. So just the specific things, not a vague thing. You're not asking to break himself all the times. No, specify things, and it is measurable. There is certain times he needs to do it. It will not disturb his life a lot. There is sometimes he needs to measure his blood sugar. Okay, then you tell him, you can easily remember to do this by setting a reminder for yourself on the smartphone or ask your parent to remind you. So you make for him achievable things. If he forgets, there is something to remind him by his own, or he can ask for assistance. Okay, and then you tell him, when measuring your blood sugars, keep aiming for 4 to 7. When fasting, 5 to 10 millimole within 2 hours of eating. And if you have low blood sugar, you need to take appropriate steps to correct the situations. If high, give corrections for better DM control. So by telling him that, you will tell him something relevant to his diabetes. If he do it, he will gain something in diabetes. He will gain more control. And you just tell him about, you stuck him to particular time to have an actions. Okay, so you stuck him to the time, this timing of checking the blood sugar, at which rate he needs, and later on, if he did this while during follow-up, he will have relevant outcome. Relevant outcome, it will reflect it either changing his time and rate, or it will reflect it in his hemoglobin A1C. And by exerting some sort of discussions, he might come to you later and tell him, okay, what about if I want to, just another question, if I want to have a sport, if I want to eat a cake, what a target I need to make it? So from here, he can exert more questions. You can motivate him. Tell him what is your daily practice in the next sessions. So a lot of challenge came from blood sugars and blood sugar value and when to check, but you will start with simple things, motivate your patients, and then you will overall, every time you will gather more gain from being specific and taking these smart goals above everything you do it. So it is very nice if you adopt it. And of course, everyone, he can adopt his own style while he is just discussing something, but it's very nice one. As I like to take photos, this is what I take it from the Riyadh Zoo. Okay, moving to the second part for using using AGP report to personalize management. So talking about AGP report in class, as we said, this is the first page of AGP report. This is the metric parts, and as we tell before, or as we discussed before, we need to read it like an ECG or chest X-ray. Make sure that you pick the right patients with the right times, and make sure that he took it over 14 days, so it will give you good reflections in the bar and in the numbers, and make sure that the time active more than 70%. And as we said here, is the ready readings, ready targets for you with plus the other metrics, and this is the color bar. So whenever you talk to your patients, I will just follow the very lovely style for Dr. Richard's while interpretation for AGP reports data. He said you can speak with the patients, whatever you feel is easily understandable for him. Either you can tell him the color bar as a color, you can discuss it in color, green, yellow, red, or you can take him in a value, high, very high, low, very low, or you can take him with him about percentage, how percentage he score in his target range. I like to take the percentage, talk with the student age group with the percentage, and you can talk in hour times. You spend 11 hours only in your target, which he needed to be like at least 16 hours like that. So you will choose what things which is be familiar or easy for the patient to absorb and interact with. Okay, so then you tell him, simply you turn your computer or screen and tell the patient, what do you see about yourself? Can you comment about where are you regarding the diabetes care from this colorful bar or from this percentage? Then he will start to think with you. He start to just knock his mind. Okay, I don't know. What am I? Should be or what is the best for me? Then you tell him, okay, simply. See this bar. Okay. Concentrate on this part, mainly the green and red bar, and just you will see where are you. Okay. So I just tell him about the ideal data we want him to be in. Okay, so we want him now his target range or his green life, it is 47%. You need to success to take it at least 70%. So here talking about number, okay, in a percentage time. He spent 11 hours, we needed at least 16 hours. Okay, and the red one is reflect the low readings. Okay, of course we know before that less than 70 will be here, less than 54 will be here. Of course we need the hypoglycemia to be 0 if we couldn't, but we know in diabetic patients taking insulin we may have hypoglycemia, but the number we need it rest. The low one we need it 40%. Okay, the patient is 40%, but the deep and yellow red one we need it to be less than 1%. It took 6%. So at a glance from the first paper, we have hypoglycemia, severe hypoglycemia, which we need to get right on. So simply you talk to the patients and tell him, okay, I need more MGLR, more green, less red. Okay, and by exerting automatically more green, less red, that means you will get rid of this yellow and orange bar. And of course, you need to tell the patients we don't like the orange bar dots. We need it at least 5%, less than 5%, because it will give you a risk of TKA, most likely. Okay, so we concentrate on the bar, and automatically, if we concentrate on that bar, we just improve the other one. Okay, so more green, less red. Simple word you can tell to the patients, and he can absorb it and work on it. Okay. So second part of the data, it is ambulatory glucose profile, AGP report. Again, you tell the patients very clearly, this is the green line where I want your reading to be. This is a 24 hours readings was being exercised in a way, and then you can discuss where is the high, very high will be when, and where is the target should be here, and the low. Okay, and then as a pediatricians, first, your eye should go to the hypoglycemia because hypoglycemia is a serious one. So for this patient, you have noticeable hypoglycemia occur for him midnight, most likely during sleep time, which is very dangerous. And he have another episode of hypoglycemia, which occur at late afternoon, after 3 p.m. So you should pursue aggressive hypoglycemia first. And again, seeing the waves, how he have high or peak readings above here at 9 p.m. and another one after 6 p.m. So we have two readings or two waves in daytimes in a particular times, which is high readings, and later after finish from hypoglycemia, you should see the hyperglycemia from where it comes. Okay, most likely whenever he woke up from sleep, start to eat his first breakfast or maybe late supper, he will develop these high waves. Okay, so again, if you see the third part of the AGP reports, the first paper, you come to, as I said, the daily one, the daily glucose profile. As we said at the calendar, the red one for hyper, the red one for hypo, and the yellow one for high readings. And again, we use this wire, yeah, to see the problem. Does the problem occur most of the days? Is most of the days this hypoglycemia, or occur only during weekend times, if the patient he slept a lot or he took extra food with extra snacking with extra insulin doses. So sometimes the daily glucose profile will give you a hint which daily glucose better you need to go on the report. So if I want to see, I will go concentrate more on the day of 27 Wednesday, for example, and Saturday times when I see the daily reports. So from the first page, only the first page, we came to just what I can say, to a summary. Now I have a great idea that patients he have hypoglycemia, which occur early morning, and he have a consuming midday, and whenever he woke from sleep, he had high rate. So a lot of issue we need to work on by addressing the daily profile later on, and see where we can make our effort and where he can just improve his glycemic control, okay, either by behavior or by the insulin dose. So again, for the Dr. Richard's method, for the AGP report of AGP waves, so simply I show him the wave, but what is the most ideal wave which I need him to be in? Okay, so again, taking one patients of Dr. Richards, he was being seen during clinic visit follow-up. So the first time, well, his first AGP report for teaching one, and you see, it was not a flat lines, it was just curvy one, and it was not narrow. There is wide distance between here, the variability 43%, and it was not in the range. So we said the range is the two lines. So it was, most of it is high. So he makes some change to these patients, and he asked him to report after a specific time follow-up, and this is the next profile. The next profile, okay, start to be flat. So we don't have this surge, okay, but still it is not narrow. Still the variation 42%, and still the medium, as we discussed it in the previous lecture, it is above the range. This is the line of the range. Most of the times near to the upper limit or above the range. Okay, again he exerted more change, and he came back after times. You see, still it start to be flat, little bit narrow, variation 28%, but still it is up, not in range. So again, change some behavioral insulin doses and coming back with this ideal profile. So what is the ideal profile we need? What are we striving for? AGP report or AGP profile that we need to be flat, narrow, and in range. And this is another nomination, FNIR, flat, narrow, and in range. Simply tell your patients, we don't need humps, we don't need jumps, we need it to be very flat, safe. Okay, so this is a photo I take it from the Foundation Day for the celebration day. Enjoy it a lot with my family. Okay, so moving to the third part, how to understand and interact with curve, using this nice paper for talking about how the curve. Of course, when you see a lot of AGP reports, it will be easier for you to interpret the waves you see. But simply here is a ideal scenario of taking insulin 15 minutes prior to the meal. The blood sugar will jump slightly and come back to normals with every meal. And as we do classical teachings, we tell all our patients that they need to take the insulin 15 minutes prior to the meal to have this nice curve. If it is slightly raised due to miscalibration, but it's okay, at last it will come quickly back. But if you take it with a meal, you will have another excursion above the target, and if you take it post-meal, it will have more high spots, which will affect his control of diabetes. I mean, either in time range or hemoglobin A1C. So they need to take it 15 minutes. And we know that there is a lot of difficulty in pediatrics on taking the insulin dose prior to meals. However, we have new insulin types like Lumigef. Hopefully it will help a lot in this issue, that it can be taken immediately after food, or after, if the patient feel it, because it will exert its actions immediately, and this should be maybe in less than 1 hour. And 57 minutes it will be for his maximum absorptions. So if the patient took it post meal, or ideally after meals, it can work without affecting his blood sugars. Hopefully, new technology of insulin will help patients towards this issue, specifically taking insulin dose prior to meal when they are not sure if the patients will eat it his full meals or no. Sometimes I forget, sometimes I start while the mom preparing food. So a lot of issue exerted towards this. I hope the new insulin regimen will change it. So again, for another real scenario, real patients, compared with the data written in the paper, this, as I said, patient he took his dose prior to the meal and he have nice curve, like what we written here. Another patient, he just took his dose and after that the blood sugar shooting high for above the target which we needed. So shooting of the blood sugar above the target, we saw explosions above targets. Maybe simply he did not take his bolus 15 minutes if he using Novorapid. He didn't take it 15 minutes prior to the meal, and maybe or he did not match the food. He took it broadly. There is change in the carbs or there is high index food. He took it high glycemic index foods, which was being absorbed later. Okay. And here, another one, extended post-meal. He took his insulin here, and the blood sugar was being raised very high post-meal. For this patient exactly, again, maybe he did not exert insulin, he did not do his insulin carb ratio appropriately. That means he took high dose, low dose to his meal, or he did, and he may take a high carb index food, like eat pizza or pasta, like that. So he had hyperglycemia, which extended to us, but returned to the normal. And another scenario here for real patients, whenever he took his insulin, the blood sugar was dropped. Whenever he took insulin, the blood sugar was dropped. That means he take too much insulin dose for this particular meals. Most likely, if he used carb counting, he did not do the ratio well, or he cannot count well. So we need to reduce the doses for this particular meals. Another trend that this patient's his blood sugar was increased incrementally from at midnight. At midnight, it's going very high early, not due to pick up hormone because it occurred early times. For this reason, most likely he was being snacking or taking milk at night or anything without giving insulin dose for that. Another scenario that the blood sugar, again, it peaked like this one, but it go back to normal. For what happened for the blood sugar? It is for any reason his blood sugar was being raised. Maybe he took a snack or he took a meal with uncovered with insulin. Later on, he took a bolus. So nothing will make the hump rather than a carbs introduced, and nothing make it down unless he took an insulin dose. Make it down with this sharp level. The sharpest is raised and the sharpest is going down. Does that mean he did a correction somewhere at that times? Okay, and it seemed to be appropriate corrections. He did it to some extent, but because he did it late. Okay, and he ate first. So talking about the better overnight, this is the ideal scenario for someone. He took the insulin, and during sleep time, his blood sugars was being optimum. This is the time when he took his breakfast. Another patient with the gradual increase for the blood sugars overnight till he woke up from sleep at 6 a.m. That means most likely the basal is too low. We need to increase the basal slightly. And another scenario for patients during sleep time, he gets these slow readings. Make sure that he don't have boluses before, or he didn't do the corrections before. If no correction before, if no boluses before, if he took his dinner at least 4 hours apart and blood sugar before, after dinner was being optimal, most likely the basal is too high for him. We need to reduce the basal. Okay. So my take-home message, interpretation of CGM is tough skills like ECG or chest X-ray, which require standardized data and practice make it perfect. You can utilize many tools to aid the patients to achieve their goal and cope with diabetes. This is the Polyvat world in Riyadh. Thank you. I hope it is beneficial one.